If we go live, go live. Oh,
Great, thank you, Mike. That was a great synchronization because I see Dr. Tang and Dr. Kera ready and anxiously waiting to
just give
start the next live case from Cath Lab 6 hybrid room.
Yeah, press and click on. We go get the slides for up.
Well, we can see you and we can see your slides. Go ahead.
Yeah, so this is, I would say, case number
8.
No, case number will be 7, I think, but actually 8 by number.
Because you did the
Oh,
ASA, right?
9, okay. So this is an 82-year-old who actually initially presented and now continues to present having hematuria, being on anticoagulation for a chronic atrial fibrillation. So significant past medical history with multiple procedures. So she also had a clip in 2023, but aneurysm repair with the stent in 1998, previous bypass, COPD, and also required a pacemaker. So Chatsworth score of 8 because of age, female gender, and has blood of 3. That now she already has a bleeding risk. So if post-clip, we can also show the echo. Our MR is just between mild to moderate, and here she is, because of the bleeding risk, the question now is that, especially because of a hematuria, that should we take care of the closing of the left atrial appendage percutaneously. So if you see here, other labs are okay, hemoglobin 10.3. So this is we show the live echo. We can show the live echo.
We are seeing the live echo. We see the live T.
All right, awesome. So this is live echo. You can see her LVEF is normal. So is her right heart. She has a very enlarged left atrium,
Huge.
over 6 centimeters. Yep. And just going through here, her appendage measurements. So you can see the top line is the ostium, and then the landing zone is the bottom line here. So this is at 0 degrees, at 45 degrees. And so it's 21 and 20. At 90 degrees, 15 and 18, and then at 135. And also you can see that the 135, the landing zone will be horizontal.
Something I give it 1,000.
All these measurements were confirmed with 3D, and you can see here that on 3D, the ostium is circular, which is actually kind of rare for a left atrial appendage. Usually it's more oval shaped. So these measurements are consistent, I believe, for a 22 Amulet device. We already did the transeptal puncture. We wanted to go inferior and mid on this because of the trajectory of the left atrial appendage. So everything went well. You can see the catheter across and directed already towards the left atrial appendage. We put our wire in the left upper vein, and now we're in the appendage file. Do you want to take over?
Sure.
Question is that when you're doing the measurement, right?
Yeah.
Okay, hold on.
We have a CT scan. Go back to the slides. Go back to the slides.
Yeah, let's go back to the slides and let the audience understand what is the planning of the procedure and the utility of the CT, please.
So this is the CT scan here. So that was a good question that you raised. So based on the CT scan, if you see the measurements, I think the measurements which we got on the echo and the CT scans are similar. So ostium minimum maximum is right there, and I think the size that we have picked is about 22.
Right. So we have to understand this device, right? Very different from the Watchman Flex. This has a lobe and it has a disc. So it's two setup here. So you want the ostium, which is covered by the disc, and you want the landing zone, which is 10 millimeters from that area, and that's where your lobe is going to sit. So that's why you need these measurements. We routinely do CT scans. I know a lot of places do it in T and ICE only, but we routinely do pre-CT scans and then confirm it on T.
Very good.
George, any questions there?
No, I think this is clear that you pre-plan, you do the measurements, very similar projections to the measurements of the TE, but obviously this allows you to kind of pre-plan it with greater accuracy, and of course you refine it during the procedure as you see fit. And
So you're doing the measurements based on the device sizing based on the pre-planning CT or on the TEE that you just got, because the TEE sizing is a little bit bigger than what you got on the CT, and the device size that you're planning is 22. But based on the CT where the landing zone is, the maximum diameter you're getting is 18. So which device size are you planning to take?
Very good question. So remember, both the cases, these patients are usually NPO. So the T sizing, I like when the LA pressure is more than 12. So as soon as these patients come in, I give them 250 to 300 cc bolus. When we do the transeptal, make sure the LA pressure is over 12. And that's the final sizing I go with. Is that
You can
reasonable?
show the
Yeah.
LA pressure if you want.
So what's the LA pressure now then? Let's give us the hemodynamics if we can.
Yeah, you can.
14 to 15.
Please increase the hemodynamics. Oh, that's great. So the hemodynamic is actually, wow, well, what's going on there? You want to do a tear afterwards? The V wave is up to 45.
And what is severe?
Can we show echo live now, please? We're now showing the.
So we decided for a 22 device here.
Okay.
Right.
Go forward with the flush. Yep. Ready? Go forward with the flush. No. Close it first. Okay.
Go back to the slides. Let's just finish everything there.
Yeah, go ahead.
We have to good. Yeah. While they're getting ready.
Is any question? This is this session is a bit tricky. I know the alcohol ablation now. Any question? Please, there's a microphone here, or just stand up. I will give you a chance to ask your question from the audience. Go ahead, Dr. Kinney.
No, okay, slides. I needed to show the slides.
All right.
There.
Where are the slides?
Slides back.
The sheet size that you took is 16, or you're going to taking 14?
It's a 12 sheet here, the Amulet sheet. And what I usually do is I like to use a Cook sheet. I'll put a 16 Cook. So let's go live there, please. So I'm going to unsheet to the ball position here.
All right, let's go live and you see the TE live, please. These slides, we saw them. All right, let's see at the bottom left. Let's see how the device opens up on the TE guidance. I think it's you can go between the main fluoro and the bottom right, and you see how the lobe
Just slightly. That looks good, actually.
the lobe is the lobe has to be deep.
Anchoring completely.
It will just give it a second.
Yeah.
It's still open.
Very good.
Keeps opening.
Yeah. Is it too deep there?
It looks too deep.
Now,
Yeah.
Oh.
By the fluoro looks yes. By the echo looks no.
You can do it.
Okay, now it's anchoring well. Okay, good.
Okay, it's full up.
I actually think that maybe okay. Let's see.
In.
Well, it definitely fills it.
Yeah.
yeah, you want to try the disc?
So
The only thing I want to see is just before I open the disc here,
You want to go complete RAO check
And-
that you're
yeah.
fully.
because I want to make sure it's not canting. That's the only thing.
it's not what?
So I'm going to just,
19.
Yeah, it's good.
it actually doesn't look that bad. Let's check.
Yeah, you were horizontal with the lobe here, so that's reassuring.
Yeah. So let's go over the close criteria here for everyone. Lucy, you want to go over it or do you want me to go over it?
You can go ahead. I'll follow along color and everything.
Yeah, can we please show the echo in the big screen? And put the fluoro in the bottom left small screen.
Yeah.
Anything from the panel? Is Dr. Little still there? Steve, are you there?
No, nothing from the panel. Please go ahead with the criteria you're going to use now in order to indicate there was a successful closure, aside from, of course, staying in place.
It should be 2/3 after the circumflex.
Yeah.
And then we want to look at the lobe compression. I can already see the lobe compression.
Right.
I don't see any leak in that appendage whatsoever.
Yep, and I'm sweeping through with color. It looks good. Do you want a football?
I will football, but just quickly show me the circumflex. I'll feel much better.
Sure.
Emotionally much better. Thank you.
No problem.
Yeah, while she's looking for that, then Dr. Kera tries to move in and out to make sure this kind of sticks.
We call it the football. It's actually more like a rugby ball.
Yeah, that's what I just about to tell you. Looks rugby.
And it looks very stable. The device position hasn't changed. Compression and the orientation hasn't changed. What do you guys think?
You're 2/3 past the circ. Yep.
Yep.
Yeah, I think it looks
So I'm going to
great.
let the release here. Just make it settle down away from the mitral.
Yeah, definitely a wait for the mitral.
Yeah, I think it was actually great that you repositioned it.
Appendage, we have separation between the artist and our own. We have a nice elliptical disc. We do a top test with no movement, and there is no outflow.
Did you do tech test?
Yeah.
It was the football, rugby ball.
Sorry, Renu, were you saying something?
Yeah, no, I was just saying, I think it's a good idea that you guys repositioned it. So with Watchman, you tend to be deeper, right? But with Amulet, you can be more proximal. I think the sizing was straight on, and the disc really covers. And I think I usually just double check and make sure pulmonary vein is okay, but I don't anticipate you're gonna have a problem with the 22 size.
Yeah. Good. Does anyone have a concern? Can I release?
No concerns, huh?
Looks good.
Dr. Safi?
No concerns. Looks great.
Let's go.
Let me take one picture. Just for completion's sake. This is contrast. Sorry, I'm taking one picture, okay?
Dr. Tang, what do you say about that?
No, I think looks excellent. I think the key is to have the imaging on fluoro and echo correlate with each other. So you'll be able to see, and you can look at actually near adjacent landmarks. For example, you know the mitral clip is there, so that's the mitral
I'm
analog.
going to release, okay, guys?
Yeah, go ahead. You can
Hashtag thing, I like that.
get rid of the hemodynamics. We don't need that the thing. You can get rid of the bottom right hemodynamic screen, please.
They are trying to sabotage my release here.
No, you release. Okay, well, the obvious question that I have is that so many people have a problem with a left atrial appendage. There's a lot of AFib after surgery. I don't see any particular reason the left middle appendage plays into the heart circulation. Michael, why does it take decades for the surgeons to just routinely close the appendage? I thought the trial was positive just like a year or so ago, and it was small and all that. But I wonder if you're right there, let's say. Well, why not?
Well, it actually was a large trial, about 4,000 patients, and it was very positive. And it takes 7 years after the completion of a randomized trial
Never
to
take this
really
on.
get significant change in clinical practice, and I think we're seeing that. But it is more widely used now in patients CHA2 or greater. The issues are two. One is in reoperative procedures where it's more difficult to access the appendage, and secondly, minimally invasive right thoracotomy approaches for mitral valve where it's difficult to get appendage occlusion on.
Yeah, and interestingly, we've come to realize that the stitching wasn't enough sometimes, that perhaps it was the reopenings and there's excisions, so there are different techniques. Once they release, maybe you can update us a little bit on, what the different ways that surgical teams can clip or exclude the appendage.
Disconnected, no?
Yeah, I think you released.
It is, but it's
It's not. The cable is stuck.
yeah,
The cable is not getting free.
yeah, it's stuck on something.
Yeah, because they removed this locking pin.
Okay, very good, very good.
Remove this.
No problem. I think you're free. I can see you free.
It's a sharp cable.
Yeah. Very good. Excellent. All right, Dr. Safi, check for a fusion.
The device looks very well seated.
Lovely, lovely. It's a great result. And do you have any final comments from the lab, or should we continue our discussion here before we go on a break?
Continue your lecture. We
Terrific.
have one last case that will be another
I think it's been surprising to surgeons over the years. You're there, you're looking at it, you're over-sewing it, and because of gaps within the sutures, even though you think you're placing them close together, you see much more recanalization than you ever would have thought. So I think the surgical standard of care has gone to a clip called Atrial that's placed on from the outside. It's like a hair barrette that goes over the base of the appendage, and it's much more effective than any of the previous surgical techniques. The problem with it is that sometimes you can't get it totally down on the base, and you leave a little cuff right next to it, which actually may be more thrombogenic than if you had not done anything at all.
Interesting, because from the outside, we would think that's kind of very easy. But from the inside, you have to look for it under other structures that are not normally exposed during the bypass or whatever other operation.
Yeah.
Great.
The risk of putting the clip on is that you impinge on the circumflex coronary artery, which runs right at the base of the appendage.
Right.
Yeah, it's a jack paper from, I think 15 years ago that the suture ones, about 70% of them still had residual flow, and AtriClip is definitely better. We did publish in American Society of Echo abstract, and I think it's in submission right now, that residual cuff from AtriClip, it's about a 2% risk of thrombus in that cuff. And so that's why we always double check the presence of a cuff before we take a patient off anticoagulation that has an indication.